we talk about getting a medical diagnosis, there's this underlying expectation for you as the patient that the whole process is going to be really precise, like almost like engineering or something.
Right, like a math problem.
Exactly. You fall down, your arm hurts, you get an x-ray, and it shows that jagged white line on the screen, and the doctor just points at it and says, there it is, that's the problem.
Right. It's totally binary. Mm-hmm. It's broken or it's not broken. And, I mean, psychologically, that is incredibly comforting for people. We really like things to be visible. We want our ailments to be, easily categorized so we know exactly what the enemy is.
Yeah, but then you step into the world of neurology and suddenly it feels like that x-ray machine is just totally broken. We're looking at a diagnostic landscape that is honestly, it's incredibly murky.
Oh, absolutely. Murky is a great word for it.
Because for decades, right? If a patient presented with severe unexplainable neurological events, I'm talking sudden vision loss, paralysis, violent seizures, doctors essentially had a massive umbrella term to lump them under, and that was multiple sclerosis, or MS.
Yeah, it's kind of a catch-all for a lot of demyelinating conditions.
But we are right in the middle of a massive paradigm shift. So today, we are taking a deep dive into the April 2026 issue of Continuum, Lifelong Learning in Neurology. Specifically, we're looking at a really comprehensive breakdown by researchers E.O.N.P. Flanagan and Cheryl Hemingway.
It's a fantastic paper, really groundbreaking stuff.
It really is. And our mission for you today is to extract the most fascinating, cutting-edge insights from their work. Because, thanks to recent breakthroughs, we now know that some of these terrifying cases that were hiding under that MS umbrella are actually an entirely distinct, newly characterized disease.
Right. It's its own completely separate entity.
Exactly. It's called Myelin Oligodendrocyte Glycoprotein Antibody-Associated Disease, which is a mouthful, so mercifully we call it Mogad for short. Okay, let's unpack this. What exactly is OGI?
So, to really understand Mogad, we have to start at the microscopic level. Mogad is a very specific protein, and it's located right on the outermost surface of your oligodendrocytes.
Okay, and oligodendrocytes they're the specialized cells in your central nervous system, right? Like tiny manufacturing plants.
Yes, exactly. That's a perfect way to look at it. Their only job is to produce myelin, which is that fatty, protective insulation that wraps around your nerve fibers, keeping the electrical signals moving quickly and smoothly.
Like the rubber coating on a copper wire.
Right, exactly. And the overarching theme of this deep dive, and really the reason this research by Flanagan and Hemingway is so critical for you to understand, is that precision in biomarkers is literally changing lives right now. Well, we are finally moving away from diagnosing a patient based on just a general cluster of symptoms. And we're moving toward diagnosing them by the exact molecular target the body's immune system is attacking.
Okay, so we're really talking about an identity crisis in the world of demyelinating diseases? Because for a long time, Mogad essentially just hid in plain sight.
It did, for years.
It was misdiagnosed as MS, or sometimes another severe condition called NMOSD, which stands for Neuromyelitis Optica Spectrum Disorder. And I know NMOSD is also an autoimmune disease, but it's driven by an entirely different antibody, right?
Right.
One that attacks water channels in the brain, the AQP4 protein.
Exactly, you've got it. So for years, neurologists knew about MS, and they knew about AQP4 positive NMOSD. But there was this lingering group of patients who just didn't quite fit either profile.
They were the outliers.
Yeah, exactly. Because Mogad is an inflammatory demyelinating disease of the central nervous system, just like MS, but it behaves very differently. I mean, multiple sclerosis often had this more gradual, simmering presentation.
Right.
The clinical course is highly varied. Symptoms might slowly creep up on you over months or even years. Mogad, on the other hand, is characterized by very specific acute attacks.
Sudden attacks.
Very sudden. They come on fast, usually lasting more than 24 hours, and often peaking in severity within just a few days to a few weeks.
Wow.
Yeah. And it wasn't until the relatively recent discovery of the MOG antibody, which is the specific weapon the immune system produces to attack that exact MOG-IgG protein we talked about, the doctors could finally separate Mogad from MS and from NMOSD. Finding that antibody created a brand new diagnostic category.
Okay, so let me see if I have this straight. If MS is like general wear and tear on the insulation of electrical wires throughout a house, is Mogad more like a highly specific wire stripping tool that only targets one exact brand of insulation?
What's fascinating here is that your analogy captures the exact biological mechanism at play.
Oh, really?
Yeah. In Mogad, the immune system isn't just causing generalized simmering inflammation everywhere. It is launching a highly targeted precision strike against this one specific glycoprotein on the surface of the myelin-producing cells.
That is wild.
It's not a systemic breakdown, it is a microscopic assassination attempt. And it is that highly targeted nature that dictates exactly how and where the disease strikes a patient.
And knowing that it's this highly targeted strike really explains the dramatic, frankly terrifying ways the disease physically manifests in patients. Because reading this, it's not subtle at all.
Not at all.
Let's trace the biology here. The Mogad is heavily concentrated in specific areas, like the optic nerves, the spinal cord, and the brain. What happens when the immune system finds it there? Because Mogad affects people of all ages, but the literature points out that children are uniquely predisposed, right?
They are. In fact, Mogad accounts for about 1/3 of all pediatric-acquired central nervous system demyelinating syndromes.
Wait, 1/3. That is a massive proportion of childhood neurological events that we previously just didn't fully understand.
It's huge, yeah. When a child presents with sudden neurological deficits today, Mogad is now right at the top of the differential diagnosis list.
And the attacks themselves are incredibly severe, like for instance when it hits the optic nerve, causing optic neuritis.
Right.
Because in traditional MS, optic neuritis is usually somewhat mild, and crucially, it's unilateral. It typically just affects one eye. But in Mogad, because the antibody is systemic and hunting for that specific protein everywhere, the attack is severe and it's bilateral. It hits both eyes simultaneously.
Exactly, it's a bilateral attack.
The sources note that up to 86% of these patients experience optic disc swelling. And at its absolute worst, what doctors call the nadir, the rock bottom peak of the attack, a patient's vision can be reduced to merely being able to detect a hand moving in front of their face.
Total functional blindness.
In a matter of days.
Yes. And the presentation actually changes depending on the patient's age. In children under 12, the most frequent presentation is ADEM, or acute disseminated encephalomyelitis.
Okay, what does that look like?
Well, this is what we call a polyfocal attack. So instead of just hitting one spot, it strikes multiple focal areas across the brain simultaneously. This causes encephalopathy, which is a generalized altered mental state. A child might become extremely confused, lethargic, or entirely unresponsive.
That is terrifying for a parent. And wait, let's talk about when it hits the spinal cord, because that blew my mind. Myelitis, inflammation of the spinal cord. The literature details how incredibly aggressive this is.
Very aggressive.
At the peak of a Mogad myelitis attack, 75% of patients require a wheelchair or some kind of heavy gait aid just to move. That sounds vastly more severe than the typical MS patient we hear about. They experience symmetric weakness, profound numbness, and severe bowel and bladder issues.
Yeah, the bowel and bladder dysfunction is a hallmark of how deeply the spinal cord is inflamed. The nerve signal simply cannot travel from the brain down to the organs.
Right. There's a case in the sources of a 34-year-old woman who initially just had mild flu-like symptoms. Just a few days later, she had this rapidly progressing weakness creeping up her legs. Mm-hmm. When she got to the hospital, a bladder scan revealed a 700 milliliter post-void residual, which means she tried to empty her bladder, but 700 milliliters of urine was just sitting there, retained, because the nerve signals to her bladder were completely cut off.
It's catastrophic for the patient. And we also see attacks of cerebral cortical encephalitis, where the inflammation hits the outer layer of the brain.
Okay.
This could present with violent seizures, terrible headaches, and fever. And because of those specific symptoms, headache, fever, seizure, it's very frequently misdiagnosed in the emergency room as a stroke or an infectious meningitis.
Because that's what it looks like on the surface.
Right? Doctors will spend precious time looking for a virus or a blood clot when the real culprit is an autoimmune attack.
Okay, I have to stop you because I'm reading these case studies and I'm honestly shocked. Here's where it gets really interesting. You're telling me someone can go completely blind in both eyes, or end up paralyzed in a wheelchair, unable to walk or even use the bathroom, or have violent seizures, but their overall prognosis is actually better than some milder forms of MS.
Yes.
How is that biologically possible?
I know, it is a remarkable paradox. But it all comes back to the mechanism of the attack. Despite the terrifying severity of these clinical presentations at their peak, Mogad patients generally experience excellent functional recovery.
Wow.
The disease is highly responsive to steroid treatments. So unlike multiple sclerosis, where there is often a slow, progressive accumulation of permanent nerve death, permanent disability, and permanent scarring over time.
Right, the progressive decline.
Exactly. A Mogad patient can experience this catastrophic, paralyzing event, receive rapid steroid treatment, and essentially bounce back to their baseline. The inflammation just washes away, and the nerves heal.
That is wild. The whiplash of that experience for a patient must be unreal. You go from a wheelchair to walking again.
It's a profound turnaround.
And what's fascinating is that this paradox in their physical recovery, the way the damage just kind of melts away, is perfectly mirrored in how Mogad actually looks on an MRI scan. It leaves unique clues that look entirely different from traditional MS, provided the radiologist knows how to look for them.
Right. And this brings us to the imaging, which is where the differences really become stark. On a standard brain MRI, multiple sclerosis lesions are typically well demarcated. They look like distinct, sharply outlined little scars.
Like little black holes sometimes.
Yes. But Mogad lesions are poorly demarcated because the inflammation is so acute and edematous, meaning it's full of fluid and swelling. Radiologists actually describe them as fluffy T2 lesions.
Fluffy.
Yeah, fluffy. They look like hazy, glowing clouds of inflammation rather than sharp, permanent scars.
And if a patient comes in with that severe vision loss we talked about, a standard brain MRI might completely miss the problem. The literature is very clear here. You specifically need orbital MRIs with contrast, and you absolutely need fat-saturated images. Can you explain why the fat saturation is the make or break detail there?
Of course. So the optic nerves sit behind the eyes,
Yeah.
surrounded by a protective layer of orbital fat.
Okay.
On an MRI, fat normally shows up as a very bright, glowing white signal. Well, the inflammation of the optic nerve also shows up as a bright white signal.
Oh, I see.
Yeah, so if you don't use fat saturation, which is a specific MRI setting that essentially turns off the bright signal from the fat, that glowing fat will completely camouflage the glowing inflammation of the nerve. You'll see nothing.
The fat just washes out the image.
Exactly. But when you suppress the fat, the Mogad lesions light up beautifully. And when they do, you see that the inflammation often extends more than 50% of the entire length of the optic nerve bilaterally. MS lesions, by contrast, are usually just short little segments on one side.
Wow. And the spinal cord imaging is equally distinct, right? I read about the H sign. What exactly is that? Is the inflammation just randomly making letter shapes in the spine?
No, it's actually tracing the anatomy of the spinal cord itself.
Okay.
In Mogad, the inflammation is often restricted strictly to the gray matter in the center of the spinal cord because that's where the targeted Mogad protein is heavily concentrated. If you take an axial MRI slice, imagine looking straight down a tube that gray matter naturally forms the shape of a butterfly or an H.
Oh, right.
Because the immune system is exclusively attacking that area, you get this bright, glowing, hyper-intense H sign lighting up right in the middle of the scan.
The H sign. It's essentially a neon sign pointing directly to Mogad.
It really is.
Plus, unlike MS lesions that leave those permanent holes like we said, radiologists literally call them black holes on a scan. Mogad lesions are dynamic. Because of how well they recover, those fluffy brain clouds and neon H signs can completely resolve and disappear over time as the patient heals.
Which is incredible to see.
So, if we have fluffy brain clouds, long optic nerve enhancements, and literal neon H signs, I have to ask the obvious question. Why don't we just put everyone who walks into a neurology clinic with numbness or vision loss into the MRI machine immediately to find this?
Well, if we connect this to the bigger picture, we run into the frustrating phenomenon of radiologic lag.
Radiologic lag.
Yes. In up to 10% of Mogad cerebral attacks, if you put that patient in the MRI machine on day 1 or day 2 of their symptoms, the scan will be completely normal.
Wait, completely normal, even if they are having seizures or severe weakness?
Exactly. The clinical symptoms, the physical damage happening at the cellular level, outpace the visible tissue damage that an MRI can actually detect. The edema just hasn't built up enough to glow on the screen yet.
That's crazy.
Doctors often have to wait 1 to 2 weeks for those fluffy lesions or that H sign to actually appear on the scan.
Which is agonizing. I mean, if a patient is sitting there blind or paralyzed, you can't just tell them to wait 2 weeks for a picture.
No, you can't.
So if the MRI clues can be delayed or totally missed if someone forgets to order the fat-saturated scan, doctors obviously need a blood test, a definitive biomarker.
Right.
And thanks to this paradigm shift, they finally have one. But reading this research, it introduces a massive new problem, which is the danger of false positives.
Precisely. Mogad is diagnosed primarily using a serum test. So we're testing the blood, not just relying on a painful spinal tap to get cerebrospinal fluid.
That's a huge relief for patients.
It is, and they use what are called live cell-based assays. Instead of just taking a dead, flattened sample of the Mogad protein and seeing if the patient's blood reacts to it, they literally use living cells engineered to wear the Mogad protein on their surface in its true three-dimensional shape.
Oh, wow.
This is critical because the Mogad antibodies in a patient's blood are highly specific. They often only recognize the protein when it's folded in its natural living state.
That is incredible technology, and the International Consensus Diagnostic Criteria, published in 2023, finally standardized how to use this test. To diagnose Mogad, you need three things: a core clinical event like the optic neuritis or myelitis we described, a positive MOG-IgG blood test, and the exclusion of better diagnoses.
Right.
And part of excluding those better diagnoses involves looking at the spinal fluid anyway, right? Because in MS, over 85% of cases show something called CSF oligoclonal bands. What are those, and why do they matter here?
So oligoclonal bands are essentially generic markers of chronic simmering inflammation in the central nervous system. Because MS is a chronic progressive disease, those bands are a classic hallmark. They show up in the spinal fluid of over 85% of MS patients.
Okay, so if you have MS, you likely have the bands.
Right. But Mogad is an outside-in attack from the blood. It's acute. So those bands are rarely present. In fact, they show up in less than 15% of Mogad cases. The absence of those bands is a huge clue that you aren't dealing with MS script.
But the real danger lies in how doctors interpret the new memo blood test itself. Because the literature explains that high antibody titers, meaning the blood test comes back with a very strong positive result, like a 1 to 1,000 ratio of antibody concentration, those are incredibly reliable.
Very reliable.
If the titer is that high, combined with the symptoms, the patient almost certainly has Mogad. But low titers, a weak positive, like a 1 to 20 or 1 to 40 ratio, have only about a 50% positive predictive value.
Yeah, that's where the trouble starts.
Meaning, literally half the time a low positive comes back, it's a false positive. The patient actually has MS or a totally different infection. It's like setting a car alarm so sensitively that a stiff breeze sets it off.
That's a great way to put it.
If a clinic decides to just universally screen every single adult MS patient for Mogad, just to be safe, you're going to get so many of those low titer false alarms that the test becomes functionally useless, or you'll just cause mass panic.
You're exactly right, and the clinical consequences of that panic are severe. This is why neurologists are explicitly warned to only test patients who have the specific atypical clinical features of Mogad we've discussed.
So don't just screen everyone.
Exactly. If you universally screen a classic MS patient just for the sake of it, get a false positive low titer MOG result, and decide to change their diagnosis, the first thing you'll do is take them off their highly effective, life-saving MS disease-modifying therapies.
Oh no.
By acting on a false positive, you could expose that patient to massive, debilitating MS relapses simply because of a faulty interpretation of a blood test.
Okay, so let's say a brilliant doctor manages to thread the needle. They recognize the atypical symptoms, they wait out the radiologic lag, they get the fat-saturated orbital MRI, they run the live cell-based assay blood test, it comes back with a sky-high titer, and they accurately diagnose Mogad.
A textbook diagnosis.
Right. Now, the patient and the doctor are faced with a totally new, frankly terrifying decision regarding treatment. Let's dig into the wait-and-see dilemma.
So in the acute phase, during the actual attack itself, the treatment is aggressive, but fairly straightforward.
Which is what?
High-dose 4 corticosteroids to immediately crush the inflammation. If steroids aren't enough, doctors will use plasmapheresis, which is literally filtering the patient's blood through a machine to physically wash the attacking antibodies out of their system.
Wow.
As we mentioned, Mogad is highly steroid responsive. The literature highlights a heartbreaking but incredible case of a 6-year-old girl who presented with bilateral vision loss. Her visual acuity dropped to 2200, legally blind, with profound optic disc edema in both eyes.
That's so sad.
But after receiving covimethylprednisolone, she made a rapid full recovery. Her vision returned.
You can't even imagine what those few days must be like for a parent, watching your 6-year-old go completely blind and then getting this miracle cure. But then comes the dilemma, because up to 50% of Mogad cases are what doctors call monophasic.
Right, monophasic.
That means the patient, like that 6-year-old girl, has one horrific attack, they get the steroids, they completely recover, and then they never ever have another attack for the rest of their entire lives. The disease just vanishes.
And because of that exact 50-50 coin flip, there is currently no class 1 medical evidence to support immediately starting a newly diagnosed Mogad patient on lifelong preventative immunosuppressive drugs.
Like the monthly IV infusions or rituximab?
Exactly, or tocilizumab. Unless the patient definitively proves they have a relapsing course by suffering a second attack, or their first attack was so exceptionally destructive that the recovery was unusually poor, the standard protocol for a monophasic patient is simply observation.
So what does this all mean? You're telling me we cure this 34-year-old woman's paralysis, or we restore this 6-year-old girl's blindness, and then the doctor just sends them home to wait and see if it happens again?
Basically, yes.
That must be psychologically agonizing for the patient and their family. I mean, every single time that little girl gets a common headache or rubs her eye because it's blurry, her parents must think, here we go again, the Mogad is back, she's gonna go blind. The anxiety would be paralyzing in its own way.
This raises an important question about balancing psychological trauma with medical reality.
Okay.
The psychological toll of waiting for the other shoe to drop is immense, and doctors must be deeply empathetic to that. But as physicians, we have to look at the medical reality of the alternatives.
Which are the preventative drugs.
Right. Lifelong immunosuppressive drugs are not benign vitamins. They carry heavy, sometimes life-threatening infection risks. They suppress your body's ability to fight off everyday viruses and bacteria.
Oh, I see.
Exposing a 6-year-old child to those severe risks, potentially for decades, when there's a 50% chance she is already completely cured and will never have a second attack. It fundamentally violates the core medical principle of do no harm. We cannot justify the risks of a preventative treatment if the disease itself might already be gone.
Wow. That is a razor-thin tightrope to walk. It really demands an incredible amount of trust and communication between the patient, their family, and their neurologist.
Absolutely. It's one of the hardest parts of treating Mogad.
So, to bring all of this together for you, Mogad is truly a master of disguise. For years, it hid under the massive umbrella of multiple sclerosis. It presents with terrifying, sudden severity, plunging patients into blindness or paralyzing them in a wheelchair in a matter of days. But it offers a surprisingly hopeful, robust recovery if caught early and treated with steroids.
Yes, exactly.
It leaves highly specific fingerprints behind, like those fluffy brain lesions and the spinal H sign tracing the anatomy of the gray matter. And we now have a very precise live cell blood test to catch it, provided doctors are careful not to fall into the false positive trap.
The value of understanding this cannot be overstated. This research perfectly highlights the absolute vital importance of precision medicine in the modern era. And frankly, it highlights the importance of getting a second opinion if your clinical presentation doesn't perfectly match your diagnosis.
Exactly, because a wrong diagnosis of MS could literally mean taking the wrong heavy-duty immunosuppressive drugs for the rest of your life for a disease you don't even have.
A terrible outcome.
Which leaves us with a final thought for you to mull over. We've seen how Mogad was hiding inside multiple sclerosis for decades simply because we didn't have the molecular technology to see the specific antibody causing the damage. It makes you wonder.
Yeah.
How many other major monolithic diseases that we think we perfectly understand today are actually just umbrellas? How many are hiding dozens of highly specific, entirely curable conditions just waiting for us to find their unique biomarker?
That's the million-dollar question.
We might still be looking at a lot of muddy waters in medicine, but every new biomarker is a filter making it just a little bit clearer. Keep questioning the world around you, keep diving deep into the facts, and we'll catch you next time.